Time session. We're very pleased today to have Dr. Cristina Carter from Timberlane Allergy and Asthma. She's an assistant professor at the Larner College of Medicine in the Department of Pediatrics. She trained at NYU and then went down to the Children's National Medical Center in Washington for her residency, and then stayed on for her fellowship at the NIH. I'm very excited about hearing her talk today as a childhood allergic asthma sufferer who back in the ancient times of the 1960s went to a guy in Providence, Rhode Island named Dr. Buffum, who was, doing scratch skin tests on me and stuff and using incredibly archaic asthma drugs. And I lived through it. So, but we're so pleased to have Dr. Carter present to us today. There's a QR code for obtaining your CME for both physicians and pharmacists and nurses. And so I will get out of the way. And Dr. Carter, thanks so much for talking to us today.
Sure, my pleasure. Okay, so I can just click through and this should go to the next slide. Let's see.
Tanya, are you sharing the slide deck so that Dr. Carter will just have to say next slide?
Yeah, we can do it that way. Or Dr. Carter, if you want to click the button that shows where to share at the top, it looks like a file folder. You could share your screen, or you can just say next slide, and I'm happy to do that for you.
Okay, all right, let's try. Oops, I don't see the presentation anymore. Okay, let's try doing just next slide. Okay, so the learning objectives today. First, hello everybody, nice to meet all of you. Thanks for having me. So I'm at Timberlane Allergy and Asthma in South Burlington, and today I'm going to talk about allergies and allergic asthma, and I am going to also touch on the new EPR4 NIH NIAID guidelines that were released in 2020, and kind of address what's relevant from there. So hopefully you'll find this helpful. I tried to make it more clinical too, so you can apply what I discussed today with your patients. So the learning objectives are to define the pathophysiology of allergic asthma, to recognize the role of testing in identifying environmental risk factors for allergic asthma, and then to identify allergy control measures to improve allergic asthma control, including allergen immunotherapy. Next slide. So I want to start with a case. So you're in the office and you have a 26-year-old female with a history of mild intermittent asthma, and she's seen for her yearly physical, and her chief complaint is difficulty breathing. And you glance at her previous note and you notice that she uses Albuterol 2 puffs PRN for exercise and with viral infections. Next slide. And you'll just have to click next. Okay, so you start asking her some questions. You start with, what does this difficulty breathing feel like to you, and where is it coming from? And where is it coming from is a really important question that I use a lot in the office because, dyspnea is a really vague sensation and a lot of different things can cause it. So whenever it's unclear or, I want to keep it more open differential, I ask my patients to point to me where they feel like their difficulty breathing is coming from. And that can be really informative because it's, if they point to their chest, then obviously that will guide you in one direction, more toward asthma. But I've had people where they've come in with a diagnosis of asthma, and then when I ask them to do that, they point to their neck, and it's very clearly the neck. So then I start thinking about other things like, is this vocal cord dysfunction that's mimicking asthma? Is this poorly controlled reflux? Is this poorly controlled allergic rhinitis? So when you ask her this question, she says, it is coming from my chest and my chest feels tight. I have trouble taking deep breaths in, and I also seem more congested than usual, but that feels different. Come on, click again. So you ask, do you have a cough, and is it dry or productive? And she responds, oh yes, I have a dry cough throughout the day, and sometimes it wakes me up at night. What seems to trigger it? I've noticed that when I'm at work, it seems a little less severe, but after an hour of getting home or on the weekends, it's really bad. And click again. And when did this start and how frequently do you have symptoms? It started pretty abruptly about 2 months ago after I moved in with my new roommate, and I'm having symptoms every day. And how often are you using albuterol? Do you wake up at night coughing? I use albuterol every day at night before bed, and I wake up maybe once a week coughing. Next slide. So you can just click through a little bit. So her past medical history is she has seasonal allergies, atopic derm, which is now improved. She had an appendectomy at age 12. And social history, she lives with a new roommate who moved in about 2 months ago. The roommate has a dog and a cat. They lived in an older home that's carpeted with forced air. And for her meds, she just has an IUD, and she takes Zyrtec PRN and Albuterol PRN. Next slide. And then on exam, pertinent positives are she has some mild conjunctival injection, she has Cobblestoning in the posterior oropharynx, and you do hear expiratory wheezing in the lower lung fields bilaterally. Next slide. So I just wanted to show you a picture of what Cobblestoning looks like. So it's called Cobblestoning because the back of the oropharynx looks really bumpy, like like a cobblestone street, and that's indicative of allergic rhinitis. Next slide. So now what? What do you do now? Based on her history and exam, you believe that her difficulty breathing is due to asthma. So the next step is really going to be to classify her severity to then decide on an appropriate treatment course. Next slide. So this is a table from the asthma, I think they're called like asthma quick care reference tables, and they're also from the EPR NIAID asthma guidelines, and they're really easy to read. They're excellent. They're like an excellent resource just to have on hand. So you're going to look at her level of impairment, and she's having daily symptoms, and she's using her albuterol on a daily basis as well. So based on her impairment, you would classify her as having moderate persistent asthma. And I do want to note that, let's say she told you she's only using her SABA twice a week, you would still classify her based on moderate persistent, because you go by, what's in the highest category for the overall classification. So based on that, if you look at the bottom, there she would go to step 3 for initiating therapy. Next slide. And so this is a table for management for age plus. So step 3 in the new guidelines is a daily NPRN combo low dose ICS formoterol. And that's a big departure from prior guidelines. So looking down at the alternatives, that's what you're probably more familiar with. So like a daily medium dose ICS, which would be something like Flovent 110, 1 puff twice a day, and a PRN SABA. That's what step 3 used to be. But new studies have come out showing that a daily low dose ICS formoterol combination for daily control and PRN use is very effective. And to note is that formoterol is the LABA that's in Dulera and in Symbicort. So you're not supposed to prescribe Advair in this situation. And the reason is because of the onset of action of the LABAs. So formoterol has an onset of action, which is very similar to albuterol. It's almost immediate, which is why you can also use this Symbicort in this scenario as a PRN. But you couldn't use Advair as a PRN because it would take 30 minutes, to really start kicking in if a patient was having symptoms. So that's just an important thing to note. Next slide. So her assessment and plan, your assessment of her is that she has moderate persistent asthma. And because you heard active wheezing on exam, she has an acute exacerbation as well. And the plan then, you decide to put her on a prednisone taper. You decide to start Symbicort, the low dosing, which is 80 micrograms with 4.5 micrograms of formoterol. and you instruct her to do 2 puffs twice a day with a spacer. And for the rescue inhaler, you discuss the options. You tell her, if you want to continue using your Albuterol, you're familiar with that, that's fine. But with this new inhaler, you can also use it for your rescue dose puffs as well. And what is important to note here too is that there is a maximum number of puffs per day for the LABAs. So for Symbicort, it's 12 puffs per day. So if she's using 4 of those puffs for controller therapy, she would be allowed 8 puffs max per day, which, is really a lot of puffs. Most patients, you should be telling them, if you're using your inhaler more than once or twice a day, you should come in to see me anyway. So that's a pretty high ceiling for how much she can use in a day. And obviously you would want her to come and see you much sooner if she was feeling the need to use it that frequently. And then you also decide to refer her to an allergy specialist for an allergy and asthma evaluation. Next slide. So at the allergist office, we decide to do skin prick testing. And I just want to show you what that testing looks like if you've never seen it or experienced it yourself. So we have these little plastic lancets, and at the tip, they're very barely visible, but there's a tiny little like metal lancet at the bottom. They're disposable, and it really doesn't hurt. We call it like a prick test. It feels like a tiny, tiny little prick on the back. Or for kids, I tell them it's a scratch test, and people tolerate it well. And then we put the entire panel on the back, and then we wait 10 to 15 minutes, and we come back and we see where any wheals have developed in correspondence to the allergen, because just to go back a step, each of those little lancets is dipped into a well of a different allergen. So each little prick is a different allergen that we're testing on the back. Next slide. So this is what our, at Timberlane, we have a 44 panel that we use for adults, and this is what our recording sheet looks like for the allergens. So starting on the left, we test for Timothy, June, and Rye, which are grass pollens, and then we get into the weeds. So from sage through nettle, those are different weeds, and then we get into tree pollens. So from oak through cedar, those are tree pollens. DP and DF are different dust mites, and then we have cat and dog extracts, feather, horse, mouse, and then a bunch of mold extracts, and then a couple more trees and weeds. And our testing is based on pollen counts in Vermont. So we test the most, the highest pollen counts in the area that are, allergenic. So her testing then shows that she's positive to dust mites, cat, dog, tree, and weed pollen. We do a diluent, which is a saline control and a histamine control, and a positive is considered 3 greater than the diluent, so 3 millimeters greater. So her diluent was 0, so she doesn't have very reactive skin, so you just would use a 3 as the cutoff for a positive test. Next slide. And so then we also do PFTs. So this is an example of what the PFT readout looks like. So in our patient, you can see the gray background shows what a normal curve would look like for expiration. And her curve on expiration has this very classic scoop. And we see that scooping with asthma because those middle and smaller airways, when they're expiring as hard as they can, we tell them, to expire as hard as they can, are tight, and they're not able to get as much air out. Basically, they have, air trapping. So this is a very classic pattern for asthma. And then, going down to look at the interpretation, we look at FEV1, which is how much basically how much air you can blow out in a second versus FEC in the entire breath, and then the ratio. And, for age, we have different predicted values for ages. And then, so we compare her best breath to what's predicted. So compared to predicted, her FEV1, her FVC, and her ratio were all low. And this is consistent with a mixed obstructive and restrictive pattern. So asthma is classically an obstructive disease in which FEV1 and FVC are normal and the ratio is low. But when people have air trapping over time, you can also see a restrictive picture. So she has both low FEV1 and FVC and a low ratio. And I don't have posts on here, but if it's ever in question, usually we'll do posts. So we'll have, patients take 2 puffs of the Albuterol, wait 10 minutes, and then we'll repeat everything and see if there's any reversibility in those parameters. So diagnostic for asthma would be a 12% change in FEV1 or FVC. Next slide. So phenotypes of asthma, we generally categorize asthma as, Th2 type or non-Th2 type, or you can think about it as like allergic, eosinophilic asthma versus neutrophilic asthma. T2 refers to our T cells, our CD4 T cells, which can differentiate into different flavors, is how I like to think about it. And so the T2 flavor type of CD4 cell is an allergic cell, mediates allergic cascades. So allergic asthma can develop in childhood. It can also develop in adulthood. Versus, non-allergic asthma is obesity associated, neutrophil associated in terms of pathophysiology and, smoking related. So more of like a COPD phenotype versus allergic, although there are some mixed patterns. Next slide. A little bit about the pathophysiology of allergic asthma. I'll try to take you through this slide step by step. So on the top left corner, you can see the allergen and the epithelial cells. And the dendritic cell is basically our sentry cell, our immune sentry cell, and it's poised all over, all over the body, wherever there's an entryway to the body, a mucosal area, skin. Those dendritic cells are our little soldier cells, and they're waiting there, and they're sampling. They're constantly sampling the environment and, trying to identify problems, like a bacterium or a viral infection or anything coming through that barrier, the epithelial barrier. And so in a person who has allergic disease, this obviously isn't a normal process that happens, but the dendritic cell sees that allergen as something bad. And so it sees the allergen, and then its job is to take a specific message to the lymph node. And so it travels then to the lymph node, and in the lymph node, it interacts with naive T cells, and it primes that T cell in a certain flavor. So it gives the message that it directs to the lymph node, then tells those T cells how they're supposed to differentiate. So in an allergic process, the dendritic cell says, hey, this is the message I'm giving to you, and you need to differentiate into a Th2 cell. So then that Th2 cell sends, messages to the B cell through, cytokines, and the B cell will start to make antibodies. Some of those B cells will become long-lived, and they stay in the bone marrow for a long time, many years. Those are called plasma cells, and they pump out antibodies. And again, in an allergic process, that's going to be an IgE antibody. That's the flavor of antibody that's associated with allergic disease. And so then these antibodies go to effector cells that are also lining barrier tissues. So mast cells, basophils, and those IgE antibodies sit and prime those cells, so that next time an allergen enters, those cells are primed to react, and the IgE attaches, cross-links to the allergen, and then the mast cell degranulates. And when the mast cell degranulates, it releases histamine, leukotrienes, other inflammatory markers, and those affect an early phase response in allergy. And then the mast cell also releases IL-5, which recruits eosinophils to come to that area, and the eosinophils continue to wreak havoc. And they help initiate more of a late phase response that you can see below. So over time, you get this chronic remodeling of tissue, you get, edema, you get constriction, and you get mucus production. And so an understanding of these cells just also helps understand some of the biologics that are now available for asthma. So a lot of the biologics, like, Fasenra is targets IL-5, and that works to block eosinophils and some of these late phase responses that are involved in allergic asthma. Next slide. So now that we've done the testing in the office, we need to discuss the components of a treatment plan. And I like to discuss preventive strategies, medical therapy options, and then what we can do in terms of, long-term immune modulating therapy, and, whether or not that's even indicated. Next slide. You can click again. So you can just click through. So preventive measures, does it actually help allergic asthma? So this is from the EPR4 guidelines, the 2020 guidelines. And, when they do these guidelines, it's kind of like a Cochrane review. They review all the literature and they come up with, their general assessment of the literature. So what they found was that, single intervention studies for prevention, things like just doing an air purifier or doing a mattress cover, probably wasn't helpful in clinical asthma outcomes like reducing exacerbations, improving pulmonary function. Again, we're talking specifically about allergic asthma where there's clear allergic triggers. The multi-component intervention studies looked like there was some improvement in them, but so like HEPA vacuums, pest control might be effective. But there was no specific combo of interventions that was identified that was more effective than others. And basically, the summary was that we need more studies. It's a little bit inconclusive to really know specifically what will be helpful in multi-component interventions to have a meaningful effect on clinical outcomes for allergic asthma. Next slide. Now, that being said, I'm an allergist and my job is to help people identify the allergens and, give them strategies that I think are pretty easy in general for prevention. So I do review all the prevention strategies because my feeling is it can't hurt. And in some cases, I do feel like it really does help. Some prevention strategies are obvious. For example, someone has really bad pet allergies and their asthma is flared by an animal. Well, clearly, if you get rid of the animal, then the asthma will get better. So just to go through the different strategies for tree pollens, I review that the trees bloom from March through June, the grasses bloom from May through June, and then weeds are blooming from August through September. I always remind people, these are going to bother you when they're blooming. Other times of year, you'll be fine around a tree, you'll be fine around grass. It's just when they're blooming that you'll have issues. And I also get a lot of questions like, well, if I'm allergic to maple, can I still have maple syrup? Or, if I work with birch wood, is that okay? I said, of course, that's fine. It's the pollens that are going to be problematic. So during pollen season, you want to maintain the bedroom as a reduced exposure area. And keep windows closed, avoid fans, and try to use the AC, and then drive with windows closed. Next slide. For dust mites are year-round. They do peak in the fall, and the reason for that is because they breed in humidity. So they breed in the warmer, humid months, so they tend to then peak to get to highest levels in the fall. So, I have lots of people with dust mite allergy where they're fine in the winter, but in the fall, that's when they're really having a lot of issues. So to reduce dust mite burden, you can buy encasings like allergy covers for the pillow and mattress. And then, washing the sheets in the hot water cycle weekly can help. That hot water cycle will kill them. That's like an easy, low cost thing to do. You want to try and minimize carpeting, curtains, stuffed animals in the bedrooms. So if it's a kid who's sleeping with a lot of stuffies, I tell them to try and reduce the stuffed animals on the bed, or at least, throw those in the wash too intermittently. And then you want to try to maintain the humidity to under 50%. Next slide. So for animal prevention measures, that's year round. Obviously, getting rid of the animal, if rehoming the animal, I should say, is nicer if the symptoms are really severe, which some people do choose to do, especially if they're having respiratory symptoms. Eliminating or reducing carpet. A HEPA filter does help reduce dander in the bedroom. It's not been shown to be as helpful with dust mites, just because dust mite particles are so small, but it can reduce dander. And then allergen casings again, so you don't get that dander getting into the pillow and the mattress. An allergy appropriate vacuum. And then at a minimum, I tell patients, keep the animal out of the bedroom, or away from the upstairs rooms if that's possible, and not sleeping in the bed. Next slide. Molds are year-round. They do peak in the fall. So, this is a little bit harder, but just if there's any obvious mold, just removing it with cleaning agents, and then trying to minimize humidity and leaks, keeping humidity under 50%. Next slide. So we kind of went over this, but next step would be discussing the medical therapy options for asthma. So again, this is the chart that's really helpful. So depending on how you classify the severity, you would go to that appropriate step. So she was at step 3, but you can see step 4, step 5, step 6. Now you're getting into higher dosing of ICS LABAs. And then really at that point, we're considering like biologic drugs. Next slide. So for medical therapy options, I also, try to address allergic rhinitis. And, so our patient had mentioned she had some congestion. There's no, clear evidence that treating AR is going to improve asthma outcomes. But, a lot of times when people come in, they're really bothered by their cough. And so, the cough can be from the chest, but then it's also often from this constant postnasal drip. So I do try to address allergic rhinitis as well, of course, so that, they can just feel more comfortable in general. And then it's also less confusing, when they have the cough, where it's coming from, if you can just get it better controlled. So how to treat it depends a bit, on whether it's like seasonal or perennial. So for a person who has like year-round allergens, doing a nasal steroid is really first line before doing an oral antihistamine. So that would be something like Flonase, 1 to 2 sprays in each nostril, 1 to 2 times a day. So if it's a patient who wants to try, keep medications minimal, you can tell them to just start with that at night and then up dose if they're not having improvement. Of note, budesonide is first line in pregnancy, and it's also unscented. So for people who don't like the floral scent of Flonase, Rhinocort is a good option. And then there is azolastine, which is a nasal antihistamine. This is prescription only. And you can do 1 to 2 sprays, again, 1 to 2 times a day. If it's just seasonal and there's any sort of like steroid phobia, I come across this a lot, especially in, with parents with like little kids, they don't want to be on a steroid nasal spray. This is a really nice option. It works well too, and you can use it, seasonally, if there are just a couple seasons where they're having issues. And then if the rhinitis is really severe, either seasonal or perennial, the combo of the steroid plus the Astelin works very well. There is a product called Dymista that it combines both of them, but it's usually pretty expensive and it's not always well covered. So I usually just prescribe, the steroid and the Astelin and tell them to combine it together. So to first do the steroid spray, 1 to 2 sprays followed by the Astelin. And then, of course, we have oral antihistamine. So if nasal sprays aren't effective enough, or there's some reason why the patient doesn't want to do nasal sprays and prefers antihistamines, you can do that. So Zyrtec, loratadine, or fexofenadine are all second generation, much preferable to Benadryl, which is very sedating. And some people are still sensitive, even just to Zyrtec or Claritin. So if you have someone who says, like, I feel a little off when I take that, I always recommend Allegra. It's the least sedating of them. It's the only one that doesn't cross the blood-brain barrier. And then I also like to mention that, over the counter, you can buy all these D formulations like Allegra D, Claritin D, Zyrtec D, and those really shouldn't be used long-term. I tell patients, like, if you're having a really bad week and you want to use a decongestant for a week, fine, but it shouldn't be used every day. It has long-term effects on your blood pressure. So I tell them instead to just double their regular Zyrtec or loratadine or Allegra. That's totally safe to do, even though it says only 1 in 24 hours in the bottle, as long as they're not using the decongestant version. I have plenty of patients who take, Claritin twice a day or Zyrtec twice a day during their really bad months. Next slide. And then I did want to mention montelukast or Singulair because this has come up a bit in the news. So there was an FDA release a black box warning due to concern for neuropsychiatric side effects. And then, and I think that's been known for a while, that Singulair in some susceptible people can cause some anxiety or bad dreams. And I always warn people of that when I prescribe it. Always. I tell them, listen, this drug works. It can work well, for your allergies or for your asthma. But if you feel funny on it after a week, just stop it. If you feel anxious or depressed or having bad dreams, just stop it. Or with kids, like if you see like a big behavior change, it doesn't have a long half-life, so it shouldn't cause like long lasting issues. But there was a very reassuring article that was just published in the Journal of Allergy and Clinical Immunology in 2021. And basically what they did is they looked at whether there are associations of depressive disorders, self-harm, and suicide with use of Singulair compared to inhaled steroid use. So this was, kind of like a data mining study. They looked at I forget which data bank they looked at, but some data bank that was associated with like hospitalizations. And they found that when compared with the use of ICS, there was no associations between Singulair and hospitalizations for depression or self-harm events. And that most, psychiatric events occurred in patients with a past psych history. So I just wanted to mention that because I've had a lot of questions about that from patients. Okay, next slide. So next, the last step would then be discussing like immunomodulatory options. So allergen immunotherapy. Does this help allergic asthma? And this again is from the 2020 NIAID EPR4 guidelines. So there are 2 types of allergen immunotherapy. We have SCIT, which is subcutaneous, and that's basically the shots. And then there's SLIT, which is sublingual. So SCIT has been shown to be more effective than SLIT in allergic asthma outcomes. And the other big difference is that with the shots, we can basically combine everything that you're allergic to, in the shots. I mean, you might need more than 1 shot depending on how many vials you need, but we can treat you for everything. Versus the SLIT products that are FDA approved are just for 1 allergen. So sometimes that works really well when someone just has 1 allergen. So they come in and they just have a dust mite allergy and it's really bad. There's Odactra, and that's a pill that you can do every day at home for 3 years and you get desensitized. And I have seen really good results with that, at least with AR. And we also have SLIT for ragweed and grass. But so that's about it. We're limited with the tablets. We don't have, cat, dog, and, the tree pollens yet. So back to SCIT, the study's shown that it does improve quality of life. It reduces the risks, the use of SABA. It reduces the need for systemic corticosteroids, and it improves FEV1. Looking at like symptoms and healthcare utilization, we don't have enough data on that. And in terms of safety profile, local and systemic allergic reactions are frequent, relatively. But usually they're mild and don't require a change in treatment. If someone has a reaction, we're usually able to adjust their therapy, adjust their pre-meds in a way that we're able to get them to their goal dosing. Next page. So IT immunotherapy, what's also really important about it, and I discuss this a lot with my parents of my pediatric patients, is that it can prevent additional sensitizations, additional allergies, and it can reduce the risk of developing asthma if it's a kid who has AR but hasn't developed allergic asthma yet. So it really has been shown that it can alter the natural history of the disorder and reduce use of pharmacotherapy. And we think the reason why that happens is because IT is basically, you're basically changing your immune response. So you're taking an allergic, kind of immune response and making it non-allergic by desensitizing them over time. And that's why we think that it can be effective when it started at a young age and altering the natural history of allergies. Okay, and then you can go to the next page. I discussed that already. So I get the question like, how long is this going to help me? So the long-lasting effects are shown in studies to be at least 7 to 12 years after discontinuation of treatment. And for most patients, it's even, it's longer. It's decades. It's their whole life. They feel so much better after doing immunotherapy. They're able to participate in daily activities, being around animals, being outside without having really bad symptoms, either of AR or asthma. In some people over time, their allergies creep back, their immune system reverts back to its old ways. So occasionally we'll have people who come back like a decade, 15 years later to do a second course, but I would say that's not the norm. Most people just do one course. I have seen patients where they did a course when they were kids and then they come back like in their 30s or 40s to do a second course. And then there was a 2010 Cochrane review of immunotherapy for asthma that assessed the impact of immunotherapy on bronchial hyperresponsiveness. And what they found was that there was an overall reduction in BHR after SCIT, and treated patients were significantly less likely to develop symptoms, bronchial hyperresponsiveness, and that SCIT specifically worked on caused reductions in allergen-specific bronchial hyperresponsiveness. So we do have a lot of good evidence that it really does work for allergic asthma. And then also a steroid-sparing effect has been shown as well in multiple studies. They've done dust mite studies in children and have shown that the amount of Flovent they've needed over time has dropped dramatically. Next slide. So what are the indications for allergen immunotherapy? Allergic rhinitis, allergic conjunctivitis, allergic atopic dermatitis, and allergic asthma. Allergic atopic dermatitis is a tough one. I have a lot of patients who have eczema. Most of them, it's not allergen triggered. Occasionally there are people who have very clinical, seasonal flares of their eczema. So if they have that, then that is a lot more convincing. So, they'll say my eczema is really bad when my allergic rhinitis is bad, in the spring and summer months. So that is a specific phenotype for that. And then again, it has to be the allergic asthma phenotype too. So what does it look like in terms of time commitment? It is a big time commitment. So it's not for everybody, but it does, for those who choose to do it, they make it work. There's a build-up phase and a maintenance phase. So the build-up phase is 24 shots that they have to get through. And we start with really, really diluted amounts of their allergens. Every patient has their own set that we mix for them. So they have a set with their name and their specific allergens. and they start with once or twice weekly. If they can come to the office twice a week, they can come more frequently if their body tolerates it. And so they have to, if they come once a week, it basically takes 6 months of once a week to get to the maintenance dose. And once you get to the maintenance dose, then it's once a week. Once a month, that should say, once a month for 4 to 5 years. There's wiggle room, people go on vacation for a few weeks, we work around it. We're able to, adjust their shots. For kids that go to college, they can take their serums with them and continue to get their shots once a month at school. Or if they move to a different state, that can be a little trickier, but as long as they can come back to our office once a year to pick up new serums, then they can continue to complete it. And in Vermont, because people are, traveled quite some distance to come see us, once they get to the build-up phase, we have a lot of patients who take their serums and then get their allergy shots done at their physician offices once a month. And I have a couple of practices who are comfortable doing the build-up phase too. We give them the protocol, we discuss it. But not everybody is, because there is honestly a higher risk for allergic reactions during the build-up phase, and it takes some technique. On the nurse's part, you're adjusting the dose every single week. So if you make a mistake, you could end up in some trouble. So in terms of clinical outcomes, we expect clinical improvement within 6 months to a year of starting the shots, and then after that they continue to see improvement. There are some non-responders. I would say it's one of our most effective therapies in medicine. I would say about 95% of people have an excellent response, but occasionally there's a non-responder. So if someone after 2 years of doing this says, I just don't feel any better, then we stop early, because at that point we say it's not going to work for you. Okay, next slide. So how does immunotherapy work? So I talked a little bit about those dendritic cells, those sensory cells that are are constantly sampling our environment, and then how they direct a message to our T cells. So in allergy, the flavors of T cells I mentioned vary, and there's a very important cell called the T regulatory cell in our immune system, and it does what it sounds like. It helps regulate the immune system. And so there needs to be a balance between all the different flavors of T cells. And when that balance shifts, that's when you start to get disease. So the balance between the Th2 cells and the Treg cells is really crucial for the development or suppression of allergic disease. So when you get immunotherapy, you basically alter this cytokine milieu and the messages that are being sent to the different cells. So you start to see a decrease in mast cell and basophil reactivity. That dendritic cell is no longer, priming the T cells to become Th2 type. It's releasing IL-10 instead of allergic cytokines like IL-4, IL-5. And then over time, you get an increase in Treg cells, an increase in B regulatory cells too. This prevents then homing of Th2 cells to the tissue endothelial cells. And then with IT over time, you get a diminished late phase response as well. So you stop the recruitment, activation, and persistence of eosinophils and T cells at those allergen exposure sites. Next slide. So basically, the plan then is, for our patient, going back to our 26-year-old who's been having issues with her since she moved into this new place. Obviously, there's always the option to move out, but if she wants to stay, at a minimum, she should try to keep the animals out of her bedroom, wash her sheets weekly in hot water. If it's something that she can afford, doing allergen encasings for the mattress and pillows, and a HEPA filter in the bedroom. And then for medical therapy, we would keep her on the Symbicort, 80 micrograms, 2 puffs twice a day. We'd have her come back in a month to reassess her PFTs to see if we see any improvement in her FEV1. And then for her allergic rhinitis, we would also start Flonase, 2 sprays in each nostril at night, and I'd follow it with Astelin, 2 sprays in each nostril at night as well. Next slide. I think that's the last one. Oh, and then immune modulating therapy. We would discuss, starting allergen immunotherapy for all of her allergens. Next slide. Oh, yeah, that's the last one, just my references. And that's it. Happy to answer any questions that might come up.
Dr. Carter, this is Norm. Thank you so much. That was a wonderfully thorough presentation. I'll read some things out of the chat box. Would you advise using loratadine daily to reduce symptoms, or is seasonal recommended?
So for this patient, so I think, so first line for the allergic rhinitis is really the sprays. So for this patient, I'd probably try the sprays first. And then when I saw her back in a month, if she was still having really bad AR symptoms, I would, I'd add on loratadine. I guess I should change my response in lieu of the animals. Given that she has an animal allergy and she's around the animals all the time, I probably would actually add an antihistamine too, because of that.
Another question, will any insurance cover the HEPA filter that's might be efficacious?
That's a good question. I have not tried that. I don't know. Probably not, I would think, unfortunately.
In terms of your patients and COVID, the question says, do you anticipate any implications for patients that have had COVID? Okay, so sort of
asthma and COVID.
Post-COVID and asthma, yeah.
Yeah. So all the studies that have come out with asthma and COVID have been surprisingly very reassuring. Now there have been like big data sets looking at who ends up in the hospital with COVID and who dies. And there really has been no signal that there's an increased risk to asthmatics. And we think that might have something to do, especially with allergic asthma, with the Th2 skewing, and that somehow that's actually protective in some way against COVID. So it's not completely well understood, but there, it's not considered, asthma is not considered a high risk condition for COVID, even though plenty of health departments are putting it as a high risk condition and having people vaccinated. But I've been really trying to just like reassure my patients that, so that we should just do what we would do for your asthma. And the American Academy of Allergy actually just released a statement about this, saying that we really shouldn't be altering our asthma therapy for asthmatics just for COVID. Like, we should keep them on what we normally would keep them on, taper them off when we normally would taper them off, just because there doesn't seem to be any sort of increased risk.
So we had another question about the link between anxiety and asthma. How do you think about that?
Yeah, that's really tough. I definitely have some like really tough patients where, again, they have this feeling of like shortness of breath or like dyspnea, and maybe they have an asthma diagnosis, and so then we try higher inhalers and it's not working, and so I do try to use the PFTs to guide me or to like reassure patients. Sometimes even with the normal PFT, if they're feeling terrible, I'll do like a 1-month trial of Symbicort, and if they're not responding to it, then I'll stop it. But there was a article recently looking at perceptions of asthma in patients, and so there is a clear cohort of over perceivers of asthma, and then another clear cohort of under perceivers of asthma. And interestingly, it seems like a lot of the under perceivers are the people who actually have bad asthma, and they end up in the hospital and they don't sense that they're having chest tightening, and we think some of that has to do with the chronic inflammation actually interfering with their receptors to sense changes in their asthma and changes in their lung volumes. So they have this reduced capacity. And then we have, this cohort of people where like they can sense, the slightest little drop in their, in their lung function, even though it's nothing clinically relevant. So when I have a patient like that, who, has very clear normal testing and they keep coming back to me, that's when I really start to ask those questions like, where are you feeling this shortness of breath? Because Vocal cord dysfunction can like very commonly mimic asthma, especially in women, or I've seen this in like teenagers, athletes, where again, they do have a diagnosis of asthma. So I try to reassure them, like, you're not crazy. Like, I know you have asthma, but I think there's also something else going on that we're not addressing, because you're not getting better with, standard therapy, and your lung function looks totally normal. So, the differential for dyspnea has to be broader. So if there's concern for vocal cord dysfunction, I'll send them to like speech language pathology or to ENT. If there's concern for reflux, I might try treating that, because reflux can mimic, dyspnea, and people really get confused. And again, I tell them, sensations in the chest are really hard to sort out. They all sort of feel the same. So, that's how come sometimes people go to the ER when they're having a heart attack and they think it's reflux, or vice versa. Actually, they go to the ER thinking they're having a heart attack, but they're having just reflux, or vice versa. And then obviously in an older adult, you need to think about like cardiac issues too. Like if they're having dyspnea, like, is there something outside the lungs? So just trying to widen your differential. And if someone's not, improving as expected. And then I do try to address the anxiety, like, telling them, to try and use breathing techniques or relaxation techniques, to try and calm themselves. But speech language pathology is like really at UVM has been very helpful and really excellent with a lot of my anxious patients, and give them some really like concrete breathing techniques they can use when they're feeling restriction. And I tell them that, like, the breathing apparatus is really complex. So if you carry a lot of tension in your neck and your chest, you can feel tight. And patients seem to be more open to that, rather than me just saying you're anxious. Like, so if I explain to them that there could be some ways in which they're holding their breath and, breathing that are wrong, and they might need some sort of like PT for that, then they're open to seeing speech language and going, and they can get some really good advice on, how to relax.
Well, there was an earlier question about shot therapy and no allergists in Central Vermont, question mark. So this is part of a learning collaborative largely for primary care offices. What would you suggest in terms of an office wanting to gear up to feel comfortable, maybe making it more convenient for their patients to get their allergy shots in the primary care setting? I mean, is there a training program? How would you bring a practice along with that?
Yeah, so that's a great question. We don't have anything formal, but I can tell you we've certainly had, we're very open to having nurses from other practices come and shadow us for a day in our lab. So we've had that done by other practices where they want to be able to offer the monthly shots to patients, but the staff is a little anxious about it, and they just want to spend like a day with us or 2 days or so. We're really open to doing things like that, so we can show you, how it works. And it's not hard to do, especially once they get to the maintenance dosing. That's once a month. It's just one vial that you're drawing from, and it's the same injection, the same amount each time. So it's not changing at that point. It's a pretty standard injection. But, we just, we want to review that, like, the physicians on site are comfortable dealing with anaphylaxis, like have Epi on hand in case there's a reaction. And we do prescribe all of our patients Epipens. So we require that they bring an Epipen to each injection visit with them. But yeah, we're really open, to discussing with any practices. You can give us a call, talk to our lab manager about setting something up if you want to do that.
We really appreciate that offer. Thank you.
Sure.
There's a question, is exercise-induced asthma associated more with allergic asthma?
I don't know of, no, I don't think so. Not as far as I know. I think it can be a very separate disease process, because I have plenty of patients who are, just have exercise-induced symptoms, but they don't really, they don't have allergies. So I, as far as I know, I haven't learned of any specific like association there.
Mm-hmm. There's another question about during the COVID pandemic, have you seen sort of patterns of changes in the asthma control within your patients that might relate, to obviously fewer respiratory infections, but also maybe different cleaning standards and the like in
Yeah,
schools, for example?
I definitely have, and in two ways. One, I've seen a lot of patients who wanted to stay, or their PCPs have kept them on controller inhalers during times when they're not usually on it, because they're just worried. And there was, I especially think earlier on when we really didn't know what was going on, everyone was a little worried, so we're just keeping people on their ICS inhalers. But definitely we've seen like the kids I follow who have like typical like viral induced exacerbations in winter, they've been having much better winters. Not ending up in the ER, not getting like as frequent prednisone courses. So I've seen that in terms of viral infections. And then I've also seen the opposite, where I've seen some like adults or kids who are staying at home all the time now having a lot of problems with their animals. So, before they were, leaving the house, and maybe they had always some like mild allergies to their animals, but like now they're like around their animals 24 hours a day. And now they're starting to have some allergic asthma symptoms that they weren't having before.
Interesting. We have maybe a couple of quick ones here. Do you have patients stay a full 30 minutes after injected immunotherapy? And are you aware of a way to be reimbursed for actually doing the injections?
Yes. So yes, we keep them a full 30 minutes. That's the protocol that we require. We do not give them any exceptions to that. They can't wait in their car, or, they have to be, we have our waiting room set up so it's like spaced out. And yes, you can get reimbursed. You basically are just charging them for, I think it's just like an injection visit. So it's like a nurse injection visit, and that's how we charge for it too. I mean, we also charge, from our perspective, like we're also charging them for the vials. But from your perspective, you're just keeping the vials in your fridge, and then you're charging them for an injection each time they come.
Mm-hmm. Can you comment on storing Epipens in terms of the temperature degradation of EpiPen? What advice do you give to your patients about them?
I tell them that it's room temperature, and just to try to avoid like extreme temperature excursions. So like not leave it in their car in the middle of winter, or, in the summer for extended periods of time. But, if they're outside at a picnic, like they don't need to worry if it's a hot day. And then the EpiPens do, at least most of them, I believe, have like a clear window on them that shows the liquid inside. So I point that out, and I tell them, if there's a temperature excursion and the epi is no longer like viable, it'll turn cloudy. So if you ever see it turn cloudy, that means you need to replace it. But if it's clear, it should be fine.
And do you have a reference for any like shared decision-making tools for immunotherapy that you maybe use with your patients, or a reference for that?
I don't have one off the top of my head, but I can certainly look into it and then email you, Norm, later, and you can share it. I basically, I just try, I review, I always say, it's a big time commitment. So you have to be willing to put in the time. But it is really effective, and and it really helps, especially if you're someone who the meds just aren't working enough. You're still miserable on your medications, you're still having symptoms. And so it can really be like a life-changing therapy in terms of symptoms. And I also mentioned, like, this isn't going to go away. So if you don't like taking medicine now, you're going to be taking it for the next 30 years. Like, it's not like, I mean, some people as they age, their allergies do become less severe. But, if you're talking to a 20-year-old who has terrible allergic rhinitis, like, and it's really interfering with their quality of life. But it does depend on what they're doing. So I'll always ask them, like, what's your 5-year plan? Because if they're a 20-year-old who's like, I might move to Hawaii, or I don't know, like I might go here, I might take a job here. I tell them, then maybe it's not really the right time in your life to start something like this. And another really important point I wanted to mention that people don't seem to understand is that you can't start shots at our practice. And let's say you're on a red and then you move to Massachusetts. You can't just like go into somebody else's office, an allergist's office, and then start their red vials. You have to start all over again. So once you start with a practice, you have to use their vials because we all use extracts from like different manufacturers. And I mean, there's a couple manufacturers that make the extracts, but there's a range in which you can, like a guideline range that we use for making the extract. So someone might put a little less of this and a little more of that. It's basically like a little cocktail we make. So it's not exactly standardized. And that's why you can't just go from one practice to the next and pick up where you left off. You have to continue those vials from that office, or you could have a really bad allergic reaction. So.
Well, this has been an absolutely wonderful 60 minutes. Thank you so much.
You're welcome.
We're going to ask the collaborative folks to stay on this call. I'm not sure whether Dr. Carter can hang around for a few more minutes, but
Sure.
If you are in the collaborative, by all means, to stay on board. I'm going to give over to